Hi there, I'm Wendy McCallum, burnout and alcohol coach and wellness expert, and you're listening to Bite Size Balance, where everyday extraordinary women share their stories, expertise, and wisdom, all in the name of lifting each other up and creating a better life by design. Whether it's wellness, career, relationships, food, alcohol, mindfulness, hormones, or parenting, we talk about all things women's balance. If your life looks great on paper, but it still feels like something's missing, you're in the right place. Welcome to Bite Size Balance.
Hello, everyone. I have a fantastic episode for you today. So Sarah and I got together to co-host this interview because we both wanted to be there to talk to our guest today, who is an incredible resource around the issue of women's desire in midlife, which is a hot topic for both Sarah and I in our practices, something we talked about a lot in the WTF program that we ran, and we'll continue talking about in future iterations of that program. And I think a conversation that's going to be really enlightening for you. And I hope that you have a couple of light bulb moments. So let me tell you a little bit about our guest today. So Dr. Lori Brotto is a professor in the UBC Department of Obstetrics and Gynecology and a registered psychologist. She is the executive director of the Women's Health Research Institute at the BC Women's Hospital. Dr. Brotto holds a Canada Research Chair in Women's Sexual Health and is the director of the UBC Sexual Health Research Laboratory, where research primarily focuses on advancing the science of psychological and mindfulness-based interventions for women's sexual health. That stuff is really cool, and we talk about that in the podcast. Dr. Brotto is an associate editor for the Archives of Sexual Behavior, has over 180 peer-reviewed publications, is passionate about knowledge translation, and as such is frequently featured in the media on sexual health topics. Her book, Better Sex Through Mindfulness: How Women Can Cultivate Desire, is a knowledge translation of her research over the past 15 years, demonstrating the benefits of mindfulness for women's sexual concerns and genital pain. Without any further ado, let's get to this episode. I hope you love it as much as Sarah and I enjoyed having this conversation with Dr. Brotto. Hi, Dr. Brotto. We are so excited to have you here on the podcast. Thank you so much for joining us today.
Thank you so much for having me. It's my real pleasure to be here.
We are so excited, and I know that our listeners are going to be really excited because Sarah and I are both here today to interview you, and we have been talking a lot about all things women's midlife, with a big focus on the intersection between hormones and burnout for women in their 40s. And, you know, one of the things that I hear a lot in my practice as a burnout coach, working with women in that age range. And Sarah, I think, sees as well with her patient base, is just this feeling of something having shifted as women enter into perimenopause and menopause around their level of desire and or their libido. So the first question I want to ask you is a really simple one, which is, what's the difference between libido and desire? Because I know you use the word desire, I think, more than libido. So can you explain? I think we tend to use libido, but I feel like it's not the right word.
Yeah, it's actually not an easy question, but I think it's a really important one to start the conversation with. I think historically, experts in the field have used libido for a long time. It has historic roots since Freud talked about libidinal urges back in the late 1800s, et cetera. We have over time come to really understand libido as reflecting something more biological, innate. Some people liken it to a drive. So more kind of physical and physiological aspects of wanting. That tends to be associated more with the word libido. Yet what the research really tells us is that there's another kind of sexual desire, and probably a second kind of desire, which we call responsive desire, is highly gendered, shows up more for women than for men, shows up more in longer term relationships and shorter term relationships. And this other kind of desire is something that really emerges in response to, and that's why hence the name responsive desire. But it's the person who says, you know, I don't necessarily have desire or drive at the outset. I'm not thinking about sex all day long, but I've got good reasons to engage in sexual activity. It brings me relaxation. It helps me connect with my partner. I look forward to the orgasm on the other side of it. And so therefore I engage in a sexual encounter for those really good reasons, those motivating and positive reasons. And then over the course of the encounter, once arousal kicks in and response starts and I tune in and I notice and it's satisfying, then I want it. Then I want to continue for more purely sexual reasons. And so that's what we're talking about when we talk about responsive desire. So I tend to use desire and sexual interest more in my work simply because I do research on and clinically see people where that's what they are trying to cultivate or restore, recognizing that the other kind, that kind of spontaneous innate desire, is heavily dependent on stage of the relationship, age, hormonal and physiological factors, and might be outside of a person's control.
Okay, that is so great. That was my next question, and you totally got to it before I asked it, which is great. We were wondering about this responsive desire versus spontaneous desire, because I'm sure you're familiar with Emily Nagoski, but I had heard her speaking, I don't know, on another podcast a while ago, and she was talking about this, and it was like a light bulb went off for me, and I thought, this is it. This is the distinction that matters for me and for other women my age. It's that, you know, we so often, I think, feel like somehow failures or abnormal or like we're broken because that spontaneous desire that I think for a lot of us may have been there in our younger years is just not present in the same way anymore. Yeah. But I loved the distinction between the spontaneous and the responsive desire, because the responsive desire piece really resonated with me. And I know Sarah and I talked about this earlier, and it resonated more with her as well. So thank you for making that distinction. So with women, then the responsive desire is often more predominant or common than the spontaneous, I presume, especially as women age. Is that fair?
Yeah, that's true. And just to back up a step, it's, you know, when Rosemary Basson, my dear colleague in Vancouver, began writing about responsive desire in 1999, her first paper was gender neutral. And she said, you know, based on my clinical practice, here's what I see among people in longer term relationships in general, is that this kind of initial lusting, dopamine driven, innate physiological wanting becomes replaced with this more nurturant and responsive form of desire. And then something happened after that where I think the field interpreted it as being gender specific to women, but it was never intended to be that way. And so over the years, the model of responsive desire, or the circular sexual response cycle, has tended to be coined as a model of women's desire. But more recently, we've seen many research groups actually studying men and finding it's just as common in men in longer term relationships. Of course, in men, because testosterone levels stay very, very high and they decline slowly with every decade, but there's still that much stronger physiological contribution to their spontaneous desire than women have. So the answer is yes, definitely you see more responsive desire in women in longer term relationships, but it's probably more common in men than we think.
Okay, that's really good to know too. So just to go back, because you were talking about testosterone in men staying higher, can you just articulate as best you can? I guess I'm sure you can do this very, very well. I guess I'm saying it in as concise a way as possible so we can understand you, because I think this is a complicated question. But what the connection is between women's hormones as they shift in perimenopause and menopause and desire, whether it's responsible, or it sounds to me like it's more connected to the spontaneous desire, but maybe I'm wrong on that.
Yeah, huge field of research with a lot of kind of differing views and interpretations of the same science. Mm-hmm. So I'll just say that at the outset, because depending on what you're reading, and unfortunately, most people in the public don't have access to the original journal articles that are studying these kinds of questions. But I think it's really important that people, when possible, go back to the science, or the onus is on folks like you doing podcasts to do, a careful and clear and accurate translation of the science. So the question around, what's the role of hormones? It depends which hormone. So one thing that we know for certain is that the decline in estrogens that happen with the perimenopause contribute to vaginal inelasticity, dryness, which can contribute to pain with penetration. And if something hurts, you're going to not want to do that thing. And so what we often see with vulvovaginal atrophy associated with changes in decreases in estrogen is that a lot of women will notice changes in their desire or their motivation for sex because it hurts, not because they don't enjoy sex anymore. And so once that's restored with, a moisturizer, a topical estrogen, et cetera, and the pain is reduced and the elasticity is restored, for many women, that is sufficient to restore their interest in sex. But that's not the whole story. So we also know a lot more about the role of DHEA contributing to vaginal and genital sensitivity. And there's been a lot of really sophisticated research looking at topical DHEA for kind of restoring the physical pleasurable sensations that some perimenopausal women say has changed for them throughout the perimenopause. So they might say, I could feel tingling and pleasure and excitement when the vulva was touched. And then through the perimenopause, I could feel touch, but it wasn't associated with those same qualities of pleasure. And there's some evidence, not a ton, but the studies that have been done are done very well, showing that topical DHEA compounded can restore some of those sensations. The picture on the androgens and testosterone specifically is a lot more complex. And I don't know if we want to go there now, but it is often, as a sex therapist, that's often a question that I get asked, which is, could changes in my testosterone levels be explaining the changes in my desire?
Because women's testosterone decreases in menopause as well, right?
Not necessarily, because there's a relationship between estrogen and testosterone. Actually, for a period of time, women might have an increase in their serum levels of testosterone. Okay. The picture on testosterone is a lot more complex. So, on the one hand, there have been several randomized clinical trials of topical testosterone, gel, patch, et cetera, cream, showing improvements in women's self-reports of desire. On the other hand, there's been about 16 studies that have tried to correlate women's levels of testosterone with their levels of desire, and they find no relationship. And there's been meta-analysis is a scientific way of kind of compiling all the data. So then you sort of ask the question, well, if there's no relationship between blood levels of testosterone and desire, then why would a topical testosterone improve women's desire? And that's where a lot of the science is trying to understand, could testosterone be working through a different mechanism? Is it working on the brain? Is it working somewhere else to improve desire? So it's a really messy picture. In Canada, as we know, testosterone is not approved for treatment of low desire. That said, there are a lot of practitioners who do prescribe it off-label and women who benefit from it. So it's really something that there's no cookie cutter recipe around testosterone and sexual desire. It really needs careful kind of scrutiny and reading of the literature, plus a conversation with a trusted and knowledgeable healthcare provider.
Thank you. That is super helpful. No, that's very helpful. Sarah, I think Sarah has a question or a comment.
I had a comment mostly about the spontaneous versus the responsive desire. Many of my patients come to the office and, describe a state where they feel like they have no interest in sex at all. So they've lost, I think, the most common thing I hear is, I just don't think about it anymore. It never occurs to me anymore. And I'm wondering if that's the switch over almost from the spontaneous desire, where the hormones had more of a role with the fluctuations of hormones during a normal menstrual cycle, to this, the sort of the responsive desire, where there needs to be more intentionality around it. There needs to be more I guess prioritizing the sex as a part of your life, but not necessarily driven by the hormones. And
Yeah.
I'm wondering if that's sort of what you're talking about in just using those two terms.
Yeah. Yeah. So it sounds like the women walking into your office really represent who we all see with similar kinds of stories and situations. And the reality is the research tells us that, most people, barring my teenage son, don't think about sex all day long, don't have spontaneous thoughts about sex.
Right.
And that's a problem in a lot of the surveys that ask, some of the validated measures of desire ask about, how much over the past 4 weeks have you thought about desire? And unless the person scores 50% or more, they're actually in the pathological range. Well, think about it. Like, are any of us thinking about sex more than half of our day, waking hours? We're not. And so we need to be really careful not to pathologize what is very normal. And what is very normal, Sarah, is exactly what you've described, is that when a person brings intentionality and reasons and prioritization, combined with making sure that the triggers, the elicitors, and Emily talks a lot about this in Come As You Are around the kind of gas and brake pedal. The gas refers to what are those triggers and stimuli in her environment, through touch, through sounds, through exchanges with her partner, that reliably pull out and elicit her desire, right? And so that picture, that combination, reasons, incentives, stimuli, good mindset, prioritization, scheduling, that's pretty normal. And so the absence of erotic thoughts during the day is not abnormal whatsoever.
Can I ask you?
People say, oh, sorry, Wendy.
No, you go ahead.
So when people say, so when women come and say, it's just an interesting term, the idea of low libido. Yeah. So when they come in, they say, I have, low libido, because I always ask, because I know that they're not being asked in every medical setting. And so that's always something that I ask. But so when they describe low libido or low desire, then it seems like it's more low libido that they're talking about, like loss of that spontaneity, loss of that spontaneous desire. Yeah. And so, and that also ties in with the idea of sort of what is normal and what is low actually a pathology. Like, so the idea of
low compared to who?
Yeah, low compared to who? Yeah.
Because if her partner desires sex once a year, her desire is probably high, right? And so we often talk about discrepant desire instead of this kind of fixed absolute low versus high, because it is a very relational experience. And in the big surveys, more and more researchers are focusing on measuring discrepancy within discrepant levels of desire within a relationship, more so than absolute levels, because it makes a lot more sense that way. But yeah, what you're describing is absolutely right. So that kind of mourning of the loss of spontaneous libido is normal, and it is that change in spontaneous kind of erotic feelings and thoughts.
So it's hopeful. It's hopeful if they understand that there's a difference between those two things.
Yeah, 100%, because the latter kind, the responsive desire, can be cultivated. It's actually within our control. You can work on what are your reasons for sex. You can work on your attention and concentration and ability to stay present through mindfulness. You can work on what are the triggers and elicitors that for you at this stage in your life bring about arousal. You can work on, managing mood and other distractions, as well as context related factors that get in the way. All of that is within our control. Whereas spontaneous desire, barring changing your partner, there's not a whole lot we can do with it.
I think I think this is very freeing. This is really what we wanted you to talk about today, because Sarah and I have had lots of conversations off camera about this whole idea of responsive desire and how we're just not talking about it. So I think that the mainstream definition of desire or libido, the way we see it in the, portrayed in the media and in everywhere really, is the spontaneous version of this. And so it's easy to feel like you're somehow broken or, not normal or typical because you're not feeling that. Especially, I don't know if especially, but for the women that I talk to, they'll say, especially because they did at one time and they don't anymore. So there's this, again, there's that obvious shift there. I want to go back to the breaks piece. So I know that Emily talks about as you said, this is Emily Nagoski that we're talking about. If you're listening, she has a book called Come As You Are. And she talks about the gas pedal versus the brakes, which is, I think the gas pedal is things that make you want to go and the brakes are things that make you want to stop. And I want to talk about the brakes because you said using mindfulness as a tool that can help you to stay present in the moment and to focus in on presumably the gas pedal. I would assume it also helps you to not think about the things that can be the brakes. Yeah. So can you talk a little bit about the brakes and kind of what you're talking about there?
Yeah. So, one of the things we've learned about desire and responsive desire is that it really depends upon what are the factors that can make it respond, right? So I'll use happiness as an example. We feel happy when something positive happens to us. Someone pays us a compliment, they say something nice, we see something nice. And that would be sort of an example of the gas pedal. So something positive is eliciting that emotion or that feeling. Desire works the same way. The brakes, on the other hand, is what is operating in our environment or within us to keep what should be arising from arising. So in the example again of happiness, so someone says something nice to you, your inclination would be to respond and feel happy, but depression, right? A clinical major depressive disorder is preventing you from experiencing that joy. So that would be an example of the brakes. So within the sexual context, there's a very long list of factors that's on that list of brakes. So inhibitions, lack of information, difficulty communicating around sex. So if let's say that a person starts engaging and touching and stimulating with a partner and what they do hurts, having inhibitions or having beliefs that talking about sex is bad or wrong or dirty prevents that person from communicating to a partner, hey, that hurts. Can we shift positions? Can we change? And instead they endure the pain, which then impacts their sexual desire. So for any individual person who might be struggling with their level of sexual desire, it's important to look at both sides. Am I engaging in the things that will elicit sexual excitement for me? Keeping in mind that it's age related, it can be life stage related, it can be hormonally dependent, and the kinds of touches that might feel very pleasurable at one life stage might feel very different. So a great example is the women who will report changes in nipple sensitivity after breastfeeding. Some people completely lose sensitivity, some people totally gain sensitivity, and for some it makes no difference. But if kind of the sexual acts are referring back to pre-breastfeeding activities and not checking in that there might be a change, then that could actually be really changing the experience for the woman. So again, coming back to if a person is struggling with their desire, looking at what are the kinds of exchanges, touches, thoughts, smells that they're engaging in, and are they working to make them feel aroused? And on the other hand, what is operating within them, in their environment, between them and their partner, or in their kind of external environment, like a distraction, right? Opening your eyes and seeing the pile of laundry can be a brake pedal for some people. They open the eyes, they see the laundry, they start thinking, oh my gosh, why didn't I do that? Why don't I ever get laundry done? Why doesn't partner help me with laundry? And here I am having sex, right? You can see how the rabbit hole of thought starts. And so they're really important to know when that is operating and to ideally systematically go through each of those different kinds of things that are on the brakes and address them.
I'm thinking as you're talking, Dr. Brotto, about something a tool that I use in coaching around anxiety and inability to focus and stay present. And sometimes I tell people they have something they're trying to get done, but they can't turn their brain off to actually write everything down that needs to be done and like mentally lock it in a locker and then, put the key somewhere safe and walk away from it. And I almost feel like that might be a helpful tool for many women, before a scheduled, maybe, or non-scheduled, but probably work better in a scheduled situation, a scheduled sex event, for lack of a better word, because I can see how that constant ticker tape kind of, laundry list of stuff that so many of the women that I work with have going on constantly because they're extremely busy and have so much responsibility. I can see how that would really get in the way, and that could act as a break.
Yeah. I mean, I love your suggestion. It's kind of scheduled worrying, right? Like, let's schedule 10 minutes to just worry. You fit it all in there, and then you put it on the shelf, and you're not allowed to worry until tomorrow, like the next day. Love that suggestion. But yeah, the reality is that, I think more and more we have become a society that prizes multitasking. And there's this, again, societal belief that if you don't know how to multitask, there's something wrong with you, and everyone can multitask, right? And, I can order groceries while I'm watching my kid's soccer game while eating and have a conversation at the same time, as if it's something coveted that we want to aspire to do. But multitasking is highly problematic from a brain perspective. There's been many very sophisticated research studies from the cognitive sciences side showing what actually happens to the brain when we're multitasking. And the brain has to work very, very hard when one is shifting between tasks. It slows the brain, it results in more mistakes, and ultimately lack of kind of satisfaction with what you're doing. So there's a lot more value in just doing that one thing that you're doing. And if you're going to show up for sex, you may as well have sex while your body is having sex, as opposed to body having sex and mind processing other information at the same time. So it is a skill that, many people do find challenging just because we multitask in so much of our day. So we've gotten very good at what we think we're doing when we're multitasking. And it means that we have to practice just doing one thing at a time.
That's really helpful. Sarah?
I was just thinking that ability to be present and to not multitask would affect women who experience pain, the pain cycle with genital pain and spasm vaginismus. I always say that wrong. That if you can actually be present in the moment, and you can get out of the anticipation of pain, provided all the other things have been looked after, vaginal tissue health, pelvic floor therapy, things that we've talked about before on this podcast, that if you can actually be present, then perhaps that would have an impact on the pain. Do you find that with your research on mindfulness?
Yeah, we actually published last year a large randomized clinical trial of women who were seeking treatment for provoked vestibulodynia, which is a subtype of genital pain where women feel pain only when the vulva and vagina are touched, in contrast to women with generalized vulvodynia who might have pain all the time or when the area is not provoked, or clitoridynia, which is pain around the clitoris. So with provoked vestibulodynia, which gynecologists find very challenging to treat, and which women who suffer from it find very frustrating because there's nothing evident on a physical exam. There's no redness, there's no discharge, there's no signs of tearing or pain. And the clinical trials of the medications have found the most commonly used medications to actually be no better than placebo. So there's been this real shift in the last 10 years towards psychological skills, because we've learned from general chronic pain management that psychological skills can actually be really, really helpful. And, one of the things that you pointed out, Sarah, is anticipation of pain. We know that when a person anticipates pain and imagines that it's going to hurt, it actually directly contributes to pain intensity. There's another feature that happens called catastrophizing. And that is, when the woman with genital pain imagines, I won't be able to cope with pain during sex. My partner will leave me. And this pain will never get better. This kind of tendency to turn a situation into a catastrophe. That those thinking styles also directly contribute to pain. And it's not that she's making the pain up. This is real pain, but it's rooted in the brain, in the pain centers in the brain, as all chronic pains are. So we started about 12 years ago experimenting with mindfulness. And that's been a big part of my own research, is mindfulness in sexual health. Experimenting with this in smaller groups of patients with provoked vestibulodynia, just to see if we offer this, like, will they accept it? Because it's paradoxical, right? Because essentially what we're saying is, in order to cope with your pain, you need to pay attention to it and tune into it, as opposed to tune out and distract and do something else. And so we did a few pilot studies and then got funding from the Canadian Institutes of Health Research to do a much larger trial where we randomized women to different arms. And the findings were astounding to me, because not only did we find very significant improvements in their ability to cope with sex, in their sexual satisfaction, but in their pain intensity. So pain intensity decreased by about 60%. And those improvements were retained a year later. So we followed women for a year, and all those benefits were retained in the mindfulness group. So as a result of that work, certainly the Department of Obstetrics and Gynecology that I work in at University of BC and other centers are now offering mindfulness as like frontline care for women seeking treatment for genital pain.
Those are remarkable numbers.
They are. I wouldn't believe them if we didn't have an independent statistician do the number crunching for us. They are pretty unbelievable.
Wow. Yeah, that is really, really compelling.
And hopeful.
It is really hopeful. I mean, and this is one of the things that Sarah and I are always trying to on this podcast, is help women regain hope around midlife and a lot of these really common issues. So thank you for sharing that. That's so helpful. Can I ask you about some other research that I know you did that is fascinating to me as a burnout coach and as someone who spends a lot of time around stress management, that kind of thing? I know you did, you were involved in a research project that connected I think it was called the Mood, Stress, and Sexual Desires Study, where you were looking at stress levels and hormone levels, I think, and sexual desire. I don't know if I've got that right, but I would love it if you would explain, like, can you let us know, like, what you were looking into and what you found and what that tells us?
Yeah. So we were very interested in the role of stress, self-reports of stress and chronic stress, exactly the kind of burnout that you're talking about, Wendy. It's the daily grind, as opposed to, say, a single big traumatic event. Those can also wreak havoc on women's experiences and their brains. But there's actually evidence that it's the chronic daily to-do list that can actually be worse in some ways in terms of the brain and the stress response system. So this was a study where we recruited 250 women who reported low desire. They met diagnostic criteria for a low desire disorder. And then we had a comparable control group. And we looked at childhood history of traumas of all sorts. So sexual traumas, physical, emotional, neglect. We also measured their what's called diurnal cortisol. And so diurnal cortisol is when you look at, so when we all wake up in the morning, we wake up with high levels of cortisol, AKA the stress hormone. And over the course of the day, those cortisol levels should come down. And if they do come down, and then that is a sign that our stress response system is working well. The scientific name for that is the hypothalamic pituitary adrenal axis, HPA axis. So in folks who are chronically stressed, they don't have that ability to regulate their stress response system. And so cortisol levels stay high all day long. So we were also looking at Do the women with low desire, do they have this kind of blunted response, this kind of flat curve, as opposed to the women without desire issues? And then we also looked at the role of mood and how all of those factors predict whether a person has a desire disorder or not, and their actual levels of desire. So you can just imagine complex models with lots of statistics involved and lots of measurement, and measuring salivary cortisol over a number of days and repeating it 4 time points over time. Essentially, what we found at the end of the day was there is absolutely a relationship between stress and desire, both self-reports of stress, as well as that kind of blunted hormone, that blunted stress response system. So the women with low desire had these flat lines of cortisol. They weren't able to kind of bring their cortisol levels down. And what we found is that problems in the stress response system, combined with symptoms of depression, explained the effects of a childhood trauma on desire. Okay, so to kind of unpack that a little bit more, there's a lot of, questions and speculations about how exactly do early traumas impact a person's psychological well-being and sexual desire later on in life, and lots of different speculations as to why. And this research suggests that it probably contributes to permanent changes in the stress response system that impact a person's ability to regulate and respond to stressors, and thus contributes to changes in their desire.
Wow, that's so interesting. So for the women who are listening to this podcast, and there will be many who are thinking to themselves, I have flatlined, who are just have been in chronic stress and know they're burnt out. Maybe they have actually, someone has actually told them they're burnt out, or they're just, they just know it from all the conversations we have on this podcast about it. How can we give them some hope? What's the hopeful part of this?
Yeah, well, stress management works, and this is your bread and butter. Stress management works, and it works on more than just feelings of stress. It has these downstream effects on sexual desire and ability to be present, and thoughts about yourself and sexual self-esteem. And so investing the time in stress management, more than just kind of superficial, oh yes, I'm aware of it and I'll take care of it, like solid and implementable skills that people put in their life to truly manage stress on an ongoing basis. Like in the same way, that we do tune-ups on our car, and this should be a regular part of our life, is that we've got a regular practice or method or way. And obviously I'm a big fan of mindfulness because the science is so convincing, and I have a personal practice of mindfulness as well. And it might not be mindfulness, but that there is a method the person has and uses to manage stress. And that's the hopeful part, because that is within our control. We can't control the stressors, but we can control our stress response.
Right. Yeah. I love that. Thank you so much. One other thing I wanted to make sure we talked about, I heard you say this on another podcast. You talked about the fact, I think if I'm wrong, let me know, but I think you said that desire it's not an on and off switch. It's not a switch that you just flip. Can you explain what you mean by that? Because I also think this is very freeing for women.
Yeah. Definitely. So it's the whole idea of kindling, right? And when if any of your listeners have ever built a campfire, the idea that you start with a slow burn, and you pay attention to it, and you blow on it, and you add the paper and the wood in the right direction, and suddenly this small little kindle of a flame grows into a fire. And desire works the same way. And it touches back to what we talked about earlier around having an intention or a reason that is compelling for you. And maybe you, by the way, I actually am a big fan of planning sexual activity. If they happen spontaneously, great, consider yourself lucky. But for most people, if they want to do anything that's valuable in their life, they plan it. And so sex should similarly be planned. So if you plan it several days out, then maybe in the days leading up, you deliberately think about it a little bit. You imagine, okay, what am I going to do differently that day to help me be more present? Or what do I want to do a bit differently in terms of my own self-care so that I show up feeling my best that day? And it's the idea of kindling over many days or many hours leading up to the encounter. Versus the light switch, which is, you hop into bed and you suddenly expect yourself to be fully in the mood, fully responsive with no prep time.
Right. That's great. That's also that kindling, I think, is where that, writing down your list of worries or all your to-dos and throwing them into a, vault, it's probably a great time to do that.
Yeah.
Okay. So I'm cognizant of the time, and we know how busy you are. And we were just, again, so delighted that you set aside this time to be with us today. I think people are going to just love this conversation. Just to kind of summarize, what I am taking from this is a bunch of really great things. One is that it's totally okay to let yourself off the hook if you are no longer, or maybe have not been ever, spontaneously, what's the word? Spontaneously in the mood. Yeah. And that's okay, because responsive desire gets you to the same place.
100%.
Yes.
And take home.
Exactly. And that stress management, all the things that Sarah and I talk about on this podcast all the time. We've talked about so many different facets of this. People have heard me talk about closing the stress cycle before it starts. They've heard us talk about do something that is incompatible with being chased by a saber-toothed tiger. They've heard us talking about mindfulness, various techniques to be more present, including the number of times I've talked about gratitude and meditation and other mindful tools. All of those things are things that, when combined, will probably eventually lead to some improvements in this area for you. So it's another reason to do all of the things that you guys hear us talking about on this podcast all the time. And I think the most important takeaway that I've gotten from this, and Sarah, I want you to throw in your 2 cents at the end here too, because I'm sure you've got some other stuff to say, but the most important thing that I've gotten out of this is that there really is no such thing as normal when it comes to a desire level. And you're probably not broken, which I think it's just free. It's going to be very freeing for women. So again, thank you very much. Sarah, did you have anything you want to say in closing?
Just thank you for confirming the things that I've been talking about and thinking about with my patients for 20 years now. And I now have a different language to use to explain it, which is great, because I feel like 25 years ago, when I started in practice, that language wasn't really defined as well. And I feel like I can bring more hope and sort of, it's not, control is not the word, I guess it is, control, helping women to recognize that this is something in their lives that they can actually make a difference in. They can actually have control over it.
We call it self-efficacy. That's kind of a psychological term, but it's the same thing, that they can do something about it.
That's super. Thank you so much for bringing this to us.
Yeah.
My pleasure.
Thank you again, Dr. Brotto. Where can people find out more? Do you have, I know that at one point I was looking at a website, but I'm not sure it's still out there. Where can people find?
So we, in my research team, we do a lot around knowledge translation. So we're on all the social media channels at UBCSHR, which stands for UBC Sexual Health Research. Last year, we did an entire social media campaign around debunking myths associated with desire. So that website's still active. It's just debunkingdesire.com. You can follow me on Twitter, Dr. Lori Brotto. And if I may, my follow-up treatment manual to my book, Better Sex Through Mindfulness, is in press and will be out in 2022. So it actually walks through all the skills that we've delivered in our treatment groups around how exactly do you practice mindfulness and then translate that to sex.
Oh, amazing. Well, if you are up for it, we would love to have you back when that thing comes out.
Yeah.
We would love to talk to you about that. That's fantastic. And you have a book as well, like a previously published book, right?
Yeah, and actually Emily wrote the foreword to my book. So
and what's that one called?
It's called Better Sex Through Mindfulness.
Perfect. Okay. Well, thank you so much again, Dr. Brotto. It's been an absolute pleasure talking to you today.
Thank you. Thanks for covering this topic as well.
Hey, everybody. It's Wendy
and Sarah.
And we just wanted to let you guys know that we loved this conversation so much with Dr. Brotto. We hope that you found it as helpful and enlightening as we did. We want to go talk about this more. So we've got lots of thoughts coming out of this. And so what we're going to do is we're going to record a separate podcast episode where we debrief from this interview and unpack some of the things that we talked about briefly with Dr. Brotto, but that we feel deserve more discussion by us. So stay tuned for that episode. It's coming soon.
You've been listening to Bite Size Balance with your host, Wendy McCallum. As a burnout and balance coach, I help busy high achievers like you create a more balanced, joyful life. If you've been putting yourself last for way too long and are worried that you're burning out, grab your free burnout checklist at www.wendymccallum.com/checklist. That's www.wendymccallum.com/checklist.